cardiovascular outcomes. Under CREVAST Academy, it is guiding various clinicians across India to improve cardiovascular health among patients. So these are few glimpses of earlier CREVAST Academy. Session 1 was on statins essential for diabetic heart. Session 2 was on statin optimization need of the hour. Session 3 was the battle against arterial plaque with statin. Session 4 was the jury on statin-associated muscle syndromes. Session 5, the hidden threat, low LDL, yet high CV risk. And today we are connected for session 6 of the CREVAST Academy, which is on high-intensity statin therapy, a unified solution to cardiovascular disease management. So under today's topic, we have 3 subtopics. First, understanding coronary microvascular dysfunction. Second is effect of high-intensity statin on CMD. And third, extended post-PCI benefits, clopidogrel combination with a background of high-intensity statin therapy. So for today's session, we have Dr. Sanjeev Shah. He has been the moderator throughout the CREVAST Academy. He does not require any introduction, but just to brief you a few lines about Dr. Sanjeev Shah. He is an endocrinologist associated with Nanavati Meg Super Specialty Hospital at Mumbai. He has more than 40 years of clinical experience. He was associated with KEM Hospital in the Department of Pharmacology for more than 5 years. And he has done a research for more than 20 years and published various international and national papers. He has written more than 20 book chapters. And we are very fortunate to have Dr. Sanjeev Shah with us today. And from here on, I would hand over the session to Dr. Sanjeev Shah. Over to you, sir. Thank you.
So can I share my screen, Khushbu madam?
Yes, sir. I will just remove the screen. Yes, sir.
Khushbu, my slide is visible.
Yes, sir. It's full screen visible.
And this is the subject. So dear friends, in our journey in CREVAST Academy during last 6 months, we have touched various different subjects, and we have moved from epicardial coronary artery. Now we are moving more into finer aspects of coronary artery disease. So today we are going to expose 2 important research papers on the subject. Our first expert cardiologist would talk about how high intensity statin has an impact in relation to acute coronary syndrome, long-term secondary prevention, and how these people, if treated with high intensity statin versus not treated, would change the outcome. On that paper, we have a subject of coronary microvascular dysfunction. In short, it is called CMD. In order to understand what is CMD, my usual talk on context setting has been changed to have something what an internal medicine or a diabetology practitioner who treat huge number of patients and offer primary prevention strategy will have an ability to understand what is the subject of, actually the subject of cardiologist. So we have 2 experts, another speaker, Dr. Nitin Patki, very senior cardiologist, is going to touch upon slightly different subjects, but it is antithrombotic drugs when used, while Dr. Kathirshan is going to touch on high-intensity statin, when both in relation to long-term secondary prevention after an acute coronary syndrome. So in order to make his talk understandable and little clear for people who are average practitioners in a busy clinic across our country, our mind is not focused on something like what we don't see, which are coronaries. We see only epicardial vessels through imaging, either CT coronary or real angiography, but we don't see microcirculation. In order to make things clear for all of us, this is how I would put it, something like epicardial vessel, and going beyond that, pre-arterioles and arterioles. Capillaries are truly intramyocardial. I have put up kind of a diameter what you see, and a resistance to blood flow in larger artery to smaller arterioles to into the capillaries are equally important. But pre-arteriole to capillaries, this three component on the right side of a diagram constitute coronary microcirculation. What you see in real major epicardial coronary arteries is the block visible, resulting into MI, resulting into various SCS syndrome. And that's the place where all kind of intervention is done or revascularization is done. And the disorders which affect structure and function of coronary microcirculation should also establish a good blood supply and correction of microcirculation. But many times, whatever intervention happen in epicardial vessel may not get transferred to improvement in microcirculation, and that could result into an adverse outcome, which many times we people, an average practitioner, would wonder that a successful angioplasty has been done, but coronary reflow into an obstructed artery or into an myocardial territory is not visible. Most of the time, there is no subsequent coronary angiography done post PTCA in an immediate time period. And so we may fail to visualize. When an event happens, we try to see why things were not successful. These are some of the curiosities. And to make things clear, like I would put it here, that there are structural abnormalities in the vessels. There can be a focal and diffuse atherosclerosis, which is more visible in epicardial arteries. But as you move downwards into the small caliber blood vessels, there would be an intimal thickening, smooth muscle proliferation, and all kind of non-visible vascular changes. More important is the functional abnormality, like more tendency towards vasoconstriction, inability to have required amount of vasodilatation. So there is an abnormal vasodilatation, and these are mediated by various, other than nitric oxide, many other molecules which are not estimated in a clinical care or even only in the sophisticated care. What is visible to us in our ACS patient many times are myocardial abnormalities, which is evident on a patient case record file, like a diastolic dysfunction, extremely common. In diabetics, all the more. Left ventricular hypertrophy, extremely common in uncontrolled or chronic hypertensive people. Infiltrative cardiomyopathy, increased intracavitary pressure, and dilated cardiomyopathy. These are the people who have vascular myocardial remodeling is happening, which could have an impact on microcirculation. Again, microcirculation is not measured, but what are the mechanisms which could be responsible for coronary microvascular dysfunction? And this is what I have listed here is hypoxia-related damage, reactive oxygen species damage, inflammation being part of every disorder in obese and diabetic population, type 2 diabetes associated with high sensitive CRP and inflammation in background. And most people have procoagulant station and platelet aggregability, which is abnormal or not corrected. So all this eventually play the role in the ultimate outcome post ACCS. So I show you a various terminology. Don't get affected by that. These are called MVO, IMH, and MVI. These, some of them would be used in the subsequent talk. using various sophisticated methods, what is not listed, and I am not showing you methods to estimate all this, which is beyond our clinical care practice, but they are there in an elegant couple of articles between 2020 and 2023. Those who are interested, Aries medical team would be able to offer you. But this is what are all various terminology which are being used in relation to research. I am going to show you a couple of slides from this elegant paper published in ST Elevated MI and how this has changed the outcome in long-term prognosis. And you can see microvascular dysfunction present or absent would result into event-free survival going down and down in people in spite of reperfusion in a STEMI situation. But if there is CMD, then in long-term clinical outcome and prognosis would be bad. And how do we change this? CMD remains a therapeutic dilemma. There are no easy way that I could desire what I need present in people who undergo PTC and revascularization. But MVO remain as an independent predictor of cardiac death. My expert panel of 2 cardiologists today will try to clarify some of the doubts what a physician needs to understand on CMD. To put it simply, on the left, you see a healthy capillary in a non-infarcted myocardium. When I show you on the right, what you see looks to be reasonably, marginally abnormal ischemic capillary, but this is still trying to be resistant to hypoxia with kind of a damage which is likely to be reversible, preserved endothelial lining, stability between the 2 cell and the junction. But this could result when it is called reperfusion injury, when revascularization is established in some people with CMD. You will find inflammatory markers, macrophages, platelets, and leukocytes, and all different elements will come into an action, would result into kind of a damage to a small blood vessel. And this abnormality in microcirculation will have a long-term bad outcome, and myocardium may not recover as desirable, though we have moved over a few years from planned PTCA to PAMI kind of an action. And as cardiologist experts would agree and discuss later, that what kind of a time window after patient is diagnosed with lab markers or an ECG marker of MI, how quickly PAMI could be done would change the outcome for a patient. So this is in summary, I'm trying to show you. The couple of papers will have a terminology which would be highlighted by Dr. Katsaran. And this is what is reperfusion after STEMI can lead to incremental detrimental effects to coronary microvasculature. Multiple trials aim to target post-ischemic CMD to reduce the extent of CMD, have been planned, but there are no good clinical agents, and CMD still remains an unmet therapeutic need. So when it comes to a decision making for a physician, for a cardiologist takes a decision of intervention, patient is in his hand in ICCU using high intensity statin and all kind of antithrombotic drugs or anticoagulant, whatever is necessary in acute setting is used. But when it comes to long-term secondary prevention, we are the people, physicians, primary care, diabetologists, have to see that in long-term successful outcome for secondary prevention, and important strategies needed. So these are the treatment modality published this year in January in Frontiers of Cardiovascular Medicine, where antithrombotic, anti-atherosclerotic therapy is very important. On diabetology side, GLP-1, RA and SGLT2I are extremely important in addition to optimizing control of risk factor. But European Heart Journal published 23 guidelines which says that infarct size and microvascular obstruction are the main determinants of long-term prognosis. So to limit the size of infarct is extremely important, and that is where microvasculature, circulation, and dysfunction could play the role. All the optimizing therapy or risk factors are equally important. With this kind of a background, I simply raise a question for your mind, and my expert cardiologist, both of you, think that what kind of a prior treatment prior to SCS could prevent the bad outcome when patient has not experienced the first clinical event. It's very, very important. We take the patient lightly and we do not offer very intensive, high target oriented therapy. Is it intensive hypertension control or appropriate glycemic control for diabetic population with CV protective drug? But use of high intensity statin for both hypertensive and diabetic population or hyperlipidemia population is very, very important. So if we would have treated such a patient with high intensity statin prior to the first episode of SCS, what could have been a different outcome? With this kind of an introduction, let's move into the next subject, which is going to be very, very important paper. And for that, I have Dr. Kathir Sen, who is a senior consultant cardiologist at Apollo, prestigious Apollo Hospital at Chennai. It's a center with a very long, multiple decades of successful cardiology treatment offered way back, 40 years back, and Apollo being founded, Dr. Pratap Reddy being a top cardiologist 40 years back. He had been experienced in various departments, but Dr. Kathir Sen is all along a Chennai-based Tenley Medical College, Madurai, Madras, and all along having a rich experience and a very busy cardiologist. He is going to highlight on effect of high-intensity statin on coronary microvascular dysfunction. Dr. Kathir Sen is going to show the slide.
Okay.
Dr. Kathir Sen.
Audio not connected.
Can you hear me? Sorry, I think my connection was a little unstable. Can you hear me now?
Yeah, but
Yes, sir.
sharing the
Yes, sir.
slide.
We can hear you.
Okay. So we are in the discussion
Kathir
mode, or
Sen,
we have to go for the talk? Sorry, I lost in between.
You can stop your video so the connectivity will improve and audio would be very audible. People have to see your slide.
Yeah.
And you can share.
I will share the screen.
Yes.
Yeah.
Yeah. Can you see the screen?
No. Do you want me to share?
I will share again, sir. Stop sharing. Share the screen. Is my screen visible now, sir?
No.
No?
No.
It is showing sharing.
It's loading.
It is showing us screen sharing, but it has not come.
Okay. Somebody is sharing. Stop share or.
So if you stop sharing, I will show your slides. Dr. Kathir Sens, my slide is visible to you.
Yeah, your slide is visible, sir. Yeah.
So you can talk on, and I will change as you suggest.
So, sorry for the in-between delay. I was listening to Dr. Sanjita. Thanks for the thanks for this CRIVAS meet. So, we all know that the epicardial artery patency is the key initial determinant for establishing the flow in setting what we say the primary angioplasty in the acute coronary syndrome. But ultimately, the final common denominator is the blood flow to the myocardium, which is actually done by the last ray of hope, which is the less than 4 micrometer vessels. These vessels have a high rate of vascularity which can happen. So, in coronary microcirculation, we need to understand. So we will just go into a systematic review and meta-analysis of the high-intensity statin therapy on coronary microvascular dysfunction. So there are multiple mechanisms which play a role in coronary microvascular dysfunction. But after PCI and during PCI, there is an important mechanism where we have to improve the flow to the muscle. So percutaneous coronary intervention (PCI) is one of the widely used revascularization strategy in ACS, and early revascularization is important therapeutic modality in patients who come with acute coronary syndrome. This important determinant which we open the epicardial vessel, but the distal microvessels, if they do not open, if they are clogged by the thrombus or by the debris from the atherosclerotic clot, then there is a diffuse microvascular spasm, microvascular injury, which ultimately reduces the blood flow to the myocardium. So, coronary microvascular dysfunction is one of the important determinant where the outcomes are bad if you open the epicardial vessel, but at the same time you do not have a good flow to the distal vessels. Next slide, sir. So, with this background, there are many determinants which affect the coronary microvascular flow. So, the important effects which happen during the PCI is there is a thrombotic milieu. So, we have to have a good amount of platelet inhibition so that we have the microvascular arterioles in a normal state of circulation. And we also encounter a lot of vasospasm. So, we need drugs. We often give intracoronary during the angioplasty. We often give intracoronary drugs like nicorandil, nitroglycerin to make sure the distal microvasculature is open, and we often give adenosine and sometimes sodium nitroprusside to make the distal microvessels vasodilate. And the other important part is the inflammation. So the inflammation which happens in an acute coronary syndrome setting, whether it is in STEMI or non-STEMI, the inflammation has to be curtailed, and there is a endothelial dysfunction which happens acutely, and also there is a reperfusion injury, which means there is a edema which is in the interstitial space, which often leads to vasoconstriction. But these all are acute effects which happens in a acute coronary syndrome setting. But the same CMD, microvascular dysfunction, can also happen in chronic coronary syndrome in a patient with chronic stable angina, and most often it happens with women. That is a separate topic, but here we are looking at the coronary microvascular dysfunction, the specific setting of acute coronary syndrome. So we have interventions, but these interventions usually work in certain parts, but it does not work when the patient presents very late. For example, if the patient presents 6 hours, 12 hours late after an MI, we often encounter resistant thrombus and resistant microcirculation, which often do not respond to the drugs what we give. Next slide, sir. So the objective of this study is actually the role of high intensity statin on microvascular dysfunction. So there was almost 20 studies looking at the microvascular dysfunction in terms of high intensity statin therapy. So this is specifically in response to post PCI patients. Next slide, sir, please. So basically, this is the inclusion exclusion data. The patients are included in all these 20 studies or patients who underwent an angioplasty in the acute coronary syndrome. So the inclusion is patients who come with STEMI or non-STEMI acute coronary syndrome taken up for PCI or included. Next slide, sir, please. So all non-randomized studies were excluded from this meta-analysis. So basically, included patients were patients with ACS, and also certain patients with stable angina were also included. And they were divided into two groups. One group, the patient who are on high-intensity statin. So basically, high-intensity statin, we know well, it is either atorvastatin 40 to 80 milligram or rosuvastatin 20 to 40 milligram. So they were divided into high-intensity group. And those patients who were on the low dose or low intensity of statins were on the other arm. So these patients were studied for the microcirculation flow. Normally, there are two measurements of microcirculation which can be measured during the angiogram. One is the TIMI flow, which we call TIMI 1, TIMI 2, TIMI 3, and TIMI 4. So TIMI 3 flow being the best outcome in terms of post PCI. And there is another grade called myocardial blush grade, where we look at, after finishing the angioplasty, how the blush of the myocardium looks. So blush means there is a good amount of contrast which reaches the final most part of the myocardium. So these are which is one angiogram. But there are other measurements which can be done specifically in the setting of chronic coronary syndrome, not in the acute coronary syndrome, but in the chronic coronary syndrome. The two most important measurements are, one is coronary flow reserve, CFR, and other measurement, invasive measurement, is IMR, which is index of microvascular resistance. Here specifically a wire is passed which has a pressure sensor, and also the flow can be estimated by using a thermal sensor. So there are two sensors. So we measure the flow and we also measure the resistance. From both the things, we can have an index, which is the invasive index. Here, two studies have used the interventional measurements, like the index of microvascular IMR. Next slide, sir, please. So one is the TIMI grade, what we look at the final flow. So when the flow which is in the initial part of the blood vessel, suppose imagine a blood vessel is around 300 millimeters long, and the final endpoint of the vessel, the distal part of the vessel, the flow is reaches within the 20 milliseconds, and there is a good flow into the entire circulation filling the distal vessels. It is called TIMI3 flow, where the flow is very sluggish. It is not even reaching the mid part of this. It is called the, and this is now considered the gold standard non-invasive measurements. But other measurements, what we look at, the invasive or different. Next slide, please. So this is the index of microvascular risk, IMR. So this is a specific measurement. This is now the most reproducible measurement of microvascular resistance. This is often in research settings, but it is slowly being taken into clinical practice. Between the pressure wire and the thermal wire sensor, it is not now integrated into clinical practice. It is expanded. Both the flow and also the pressure is measured, and from this resistance index is right. So any measurement more than 25 means it's a norm. So level means a good amount of flow. Next slide, please. Yeah. So this is the results. So in both the study groups, when we look into the analysis, the high intensity statin group, if you look at this, the high intensity on the left hand column, the high intensity statin group had a good outcome in terms of good distal flow, which basically means good amount of microcirculation preserved. So high intensity statin therapy in the acute setting and also in the chronic setting preserves the microvascular flow, and the outcomes are good in the high intensity of PCI patients. Next slide, sir, please. When you look at the invasive measurement of IMR, here also in the two studies, resist ACS and also in the T et al. Study, they have specifically shown most of these studies are done in the South Korea, where there is a high amount of research going on in the microcirculation. So here there is a specific improvement in patients who are on high intensity statin therapy. So the high intensity statin therapy specifically preserves the microcirculation when it is given pre-PCI. So it should be an important armamentary in our drug therapy to maintain the microcirculation. Next slide, please. So we all know the statins are pure, but the effect is mainly in terms of coronary mainly in terms of endothelial action. One. The second has been on the prevention of the reperfusion injury. So these are the two important pathophysiological markers, or what we can say pathophysiological mechanism, which has been indirectly proved when you give a statin therapy. So one is the endothelial function, which is relatively preserved, and second is the acute reperfusion injury, which happens because of multiple mechanisms. Apart from the platelet effects, it is because of the endothelial function myocardial edema, which happens, and this has been specifically shown the benefit when you do a high intensity statin therapy. So I think over to Sanjeev Shah for this session.
So I have a couple of questions for both the experts. As I and Dr. Nitin Patki and all of you were listening to what presentation. So first question for Dr. Patki. When you receive over a large many years of experience, when people come with acute coronary syndrome, in your own experience, and first you will answer, then Dr. Kathirsan will answer, what is kind of an LDL with these people, and what kind of a statin they were receiving when patient was received in ICCU with acute coronary syndrome. So these are the people who were high risk or moderate risk. They were likely to develop ACS in future, but still treated in whatever way they were treated by our physicians in our community. And this is the patient you receive in ICCU for treatment of ACS.
Yeah, thanks, Dr. Sanjay Shah, and it was a very good introduction you gave. As you mentioned, microvascular dysfunction is really a big problem, and statins can play a huge role preventing it, and of course in future to avoid future complications. That's absolutely true what you said. Now, as regards to your question, most of the patients who come to our ICUs or casualties with acute coronary syndrome, many of them, especially STEMI patients, they are on statins therapies, and they have not measured their LDL cholesterol or lipid profile. A small percentage of people who were previously diagnosed as diabetic or hypertensive, even in those patients, routinely, if we check, they have not undergone the lipid profile checking and management of statins as such. So, unfortunately, it's a small percentage of people who receive guideline-directed therapy and can be prevented not only microvascular dysfunction, but even the coronary events if they are treated with statins adequately beforehand. So that is one important point we should carry home when we end this talk. There are some diabetic people who will be on statins, but that too still not adequately. One of the important factors is reluctance from the patients to take medicines, especially when they do not have coronary events. And sometimes it is reluctance on part of physicians also to treat these lipid abnormalities aggressively. So that is definitely there. But when these patients come with ACS, first initial loading dose what we give always includes a high intensity statin before the patient comes on table. That may or may not really help. As you can say, absorption will take time, effect will take time, but we always load these patients who are coming for primary angioplasty or angioplasty receive higher stuff.
Dr. Patki, you try to do when the patient is received and as quickly the loading dose could be delivered. We wish that if they would have been on high intensity statin, their probability of getting ACS or MI would have been anyway lower. But if we look at Interheart study and Dr. Salim Yusuf's paper and subsequent paper, are people getting recognized in preventive cardiology that they are likely to be high risk MI patients? We know that diabetics are anyway into high risk. We have addressed diabetes and high intensity statin couple of times in the last 6 months at various different part of our CREVAST Academy. But other than diabetic people, what do you think? How do we identify population who would receive high intensity statin for primary prevention?
So, as you mentioned, diabetics are the people who are most likely to land up with ACS. Similarly, hypertensive people or people who have a significant family history of ischemic heart disease, and many of these young population in their health checks do get lipid reports which are abnormal. These definitely need high intensity statin therapy. Additionally, I would suggest that those people who are in high risk job profile, high stress situations like directors or high post people or finance people who are always at high risk, high stress. Those are the people who land up with coronary events, especially because of stress. They are also many times going to land up with diabetes and hypertension. So these high risk populations should probably be having their regular medical health checks, which includes lipid profiles, LPA, and things like HSCRP, which can tell us whether the inflammation is there, which could be an indicator of unstable plaque, and should be treated with high intensity statin therapies.
So technically, we have to identify that who are within the risk factor category also, who has high likelihood of landing up with trouble. Probably two major risk factors would be diabetes and smoking, or hypertension with diabetes, in which both are uncontrolled, whose lifestyle is not good, or who have other risk factors like air pollution, odd sleep hours, and many more. So I have a little different question for Dr. Kathirsan. Are you there? Kindly unmute yourself.
Yeah, yes, sir, I'm listening. I'm here, yeah.
So I'm putting a different question in relation to CMD. You have a patient who has been subjected to intervention PTCA after ACS. In subsequent 24 hours, 48 hours, when patient is being closely monitored in ICCU by you and your team and similar cardiologists in other settings, how do we judge, how do we assess, or is there an indirect method of assessing the outcome part, because you are not subjecting the patient to repeat angiography, that how circulation is well established and probably also a focus on CMD. Yeah. How do you assess post-PTCA in an ACS?
This is a very important aspect. What we normally do when we leave the cath lab, we of course look at the M3 flow and also the myocardial cluster rate. The most important element what we have seen is the ECG is a reflection of your microcirculatory flow. So if you have a patient coming with ST elevation high, sky high, and then you have a good ST resolution, and then when you look at the next day, there is a T inversion happening when the ST resolution happens. This is one of the important determinant marker what we see in our day-to-day practice, that the final flow has been established to the muscle. The other way of doing it is the patient has a good hemodynamics, and also if you look at the echocardiogram, Sometimes we receive a patient within 1 hour of an angiography, we have regional wall motion abnormality all over the LAD territory, and then the next day itself the LAD territory recovers, and the ECG there is a good amount of SC resolution happening. So in one point hemodynamics, but the marker will be the ECG changes, the evolving ECG.
Dr. Patki, on the same line going further, in your large experience over more than 30 years, how do you assess that some patient is likely to, in spite of PTCA, is likely to fall into certain complication, which could be heart failure, rhythm, or blood pressure fluctuations? This is for people, large majority of our listeners who are not into ICCU kind of a practice, who refer the patient and then they don't see when what has passed through in a week or 2 weeks during cardiology management in the hospital.
Yeah, very important. And I'm sure Dr. Karthi sir will also agree. The most important determinant is how to open up. So if the onset of the time of opening of the artery is the most damage is less, the microcirculation functions well, and the myocardium is actually reperfused. So the key element is if the patient is getting delayed treatment, that is one person who is, despite opening the epicardial artery, is going to land up with LV dysfunction, arrhythmias, and even death. And of course, the survival is going to be less. So that is one important aspect we should look at. The earlier presentation is essential, and all those patients who are referring these patients for treatment for acute coronary syndrome, especially STEMI, should make it a point that patient reaches a cath center very early. Now, there is additional therapy which is available, which is now called as pharmacoinvasive therapy. In case the patient is getting delayed, they at least get thrombolysis, and then within first 24 hours get the and SOS angioplasty. So that is one. Second is really re-established. The TB grades are there. The myocardial blush grades are there. Now, the finer measurements by flow wires are not commonly performed in every angioplasty or every STEMI primary angioplasty, but are very important clinical indicators which on table will tell us that this myocardium is really well perfused and is likely to recover. The third thing is, of course, as he mentioned, the ST changes. And finally, the behavior of the patient during first 24 hours. Many times when we do angioplasty, it's not only the microcirculation, but the distal embolization of the plaque material, distal embolization of the thrombus, that also affects the myocardial performance later on in life. So the large infarct, delayed presentation, and not so good flow established during primary angioplasty are the indicators that the patient is going to land with problems. We can always treat them prophylactically with some medications like mineralocorticoid receptor antagonist and high intensity statins, beta blockers. These will help. But if the myocardium is baseline damage, even these measures do not really save the patient to a large extent.
Thank you, Dr. Patki, for that comment. Now we touched upon two areas. We all agree that post-ACS, post-revascularization, such patient is likely to receive high-intensity statin as indicated in guideline. If they would have received prior to, would have been different. The next issue comes on antithrombotic therapy, and that also has equal contribution along with statin, of course, not without statin. And in the mind of large majority of the practitioner, aspirin had been the main drug. Aspirin in recent decade came under kind of a suspicion. Is it truly the right drug? And there are people with low dose tolerance issues, aspirin resistant, and whatnot. So whether there should be 2 antiplatelet or 1 antiplatelet, these are high risk people post SCS, and then we want to prevent a subsequent attack. So in order to sort it out, we have kept this second important paper in relation to aspirin versus clopidogrel, which has been successfully used as a single agent or a combination, and which one is better in long term along with statin. I invite Dr. Nitin Patki as our second expert cardiology speaker today, who has been a physician, graduated from Pune University in 1988, DM cardiology way back in 92, more than 30 years, subsequently had interventional fellowship in Royal Melbourne, Australia, and has been affiliated with Wadia Institute, MFF Joshi, and Jupiter Hospital, based in Pune for more than 30 years. Speaker, key opinion leader at many meetings, and a principal investigator in many clinical trials. So Dr. Patki is going to talk on a second topic, and Dr. Patki, you will share your own slide, or
I think the you can either share or the company.
So I will continue with the sharing as it was done earlier. So you can start from here.
Yeah. Thank you, Dr. Sanjay Shah, and thanks especially for sharing the slides for me. Next slide, sir. So basically, we are talking of now the antiplatelet therapy. Of course, as Dr. Shah mentioned, the background high-intensity statin therapy is essential for all, not only acute coronary syndrome, but all coronary disease patients, whether they undergo angioplasty or do not undergo angioplasty. So once the patient is through all these basic interventions or revascularization, maybe it was angioplasty, maybe it was bypass surgery, they need long-term antiplatelet therapy. And so far, next slide please, sir. So what we know is that at least the ACS patients, this is what the basic therapy with statins is. Next slide please. Next slide, sir. Yeah. So once the patient has landed with us with acute coronary syndrome, for first year, DAPT or dual antiplatelet therapy is a must. That dual antiplatelet therapy, of course, includes one aspirin tablet and one P2Y12 inhibitor, which most commonly would be nowadays ticagrelor or prasugrel. At some point of time, it was clopidogrel, but there are many trials which say that these two are more potent, especially in acute coronary syndromes. They, of course, have more antithrombotic action, but that also causes increased bleeding risk. But nonetheless, for acute coronary syndrome, of course, the talk of dual antithrombotic therapy, especially in patients who need antithrombotic therapy, is a different issue. We are not discussing that here now. Next, please. So, what question arises is what happens beyond this first year. So we have next slide, sir. So we have so far been using this dual antiplatelet therapy for first year, definitely. But then beyond that time, there have been many papers which suggested that you stop aspirin after some time, then continue ticagrelor for about next 2.5 years or so. So multiple trials have been there. Now, what this good trial called here, host exam trial, was to study long-term effects of aspirin versus clopidogrel once this patient has gone through this initial first year of dual antiplatelet therapy without any complications. So patient has not had any thrombotic event, patient has not had any bleeding events. Now what happens then? We don't need to continue dual antiplatelet therapy beyond this first year, and then we choose one of those. Next slide please. So this trial for a couple of years that showed that actually scored over aspirin in terms of both thrombotic events and bleeding events. So the host exam showed that composite of all deaths, non-fatal MI, so thrombotic events like non-fatal MI, strokes, readmission with acute syndrome were better with this, and also the bleeding risks were better with clopidogrel. But what happened with this initial thing was there was a numerically higher risk of all-cause mortality with clopidogrel therapy. So therefore, we were not sure exactly what we are dealing with, what was the reason, and there was no clear indicator what was happening with this first 2 years. So this same group of subjects which were studied for this initial 2.5 years were studied for a longer period of time, over a period of few years, beyond 2 years, and then the results were compared. Next, please. So the initial conflicting results were studied. Of course, the background therapy of high intensity statin was there in most of these patients. The clopidogrel arm was and aspirin arm was more or less a similar number of patients. Statins were always there. And additionally, other standard of care therapies like ACE inhibitors or ARBs, beta blockers, nitrates as required, and SOS proton pump inhibitors were also given. Next, please. So the idea was to see which scores better, whether it was clopidogrel which was coming out stronger or whether it was aspirin which was coming out stronger in patients with coronary angioplasty for acute coronary syndrome. These are the basic demographic data which are there. The follow-up was over 5.8 years, so let us say about 6 years or so. Next, please. So what we are looking at is really long-term data in these patients, not just first initial 1 year or 2 years, the long-term data. And it's a complicated chart, but basically what we are looking at was what outcome was there in these two groups. Next, please. So results, what were seen there was primary endpoint occurred in lesser number of people who received clopidogrel as compared to aspirin. Now, what was the primary outcome? The primary endpoint was all-cause death, non-fatal myocardial infarction, strokes, so all thrombotic risks, and also the bleeding. So every complication, every known thing which could happen or go wrong, which in a patient, you know, what we are worried is not one complication or the other. What finally happens to the patients is important, and therefore all the thrombotic complications and the bleeding complications, both taken together, still clopidogrel scored better over aspirin. And this is an important thing, which was little different compared to the initial 2 years, where it was more in terms of numerically more in terms of clopidogrel, the all-cause deaths were higher. Next, please. So here, all-cause mortality or all risk factors were taken together. Clopidogrel was better. Now, what was the second outcome? Secondary was thrombotic events, which will mean that there was some thrombotic complication in the coronary artery, in the infarcted or the stented segment or somewhere else, or in the brain. So all these ischemic events were taken together and compared between aspirin and clopidogrel, and here there was a significant reduction in thrombotic events in clopidogrel arm. So even the separate group where thrombotic risk is taken as an indicator, the clopidogrel as an anti-thrombotic agent or antiplatelet agent scores better over aspirin. So one thing is sorted out, that it is definitely not a weaker antithrombotic agent. It's definitely a good antithrombotic agent compared to aspirin, and we should have no harm taking this event in terms of thrombotic complication. Now, what about bleeding complications? So even bleeding complications, the clopidogrel arm was better in terms of bleeding. So all BRC grade 2 and above bleeding complications were much lesser. So there may be some minor bleedings which can happen with clopidogrel also, but overall higher grades of bleeding which will need transfusions or admissions, that are definitely lesser as compared to aspirin. Next, please. So basically, all the events which can go wrong in a patient who has received a stent or who has been under treatment for acute coronary syndrome in long term, that is, we are talking of beyond a couple of years, what we are talking of is treating these patients as a monotherapy for antiplatelet therapy. Aspirin should be kept as a second line, and clopidogrel should be kept as a first line in terms of monotherapy and mono antiplatelet therapy. Next, please. So this is a chart which will tell us various reasons why it should be used. So the extended follow-up of post-exam study showed persistent benefits of clopidogrel over aspirin in terms of all-cause mortality, in terms of all thrombotic events, and in terms of all bleeding events. So medication discontinuation was especially important in aspirin, as Dr. Sandesh was mentioning initially. Gastritis, occult bleeding because of aspirin is very common. And therefore, this again is one important point why we should be using these patients with clopidogrel. We understand the importance of discontinuation of these therapies, as this is likely to develop into complications like thrombotic events. So the patient, even if in trial settings, if the patient both the agents were continued, still there was a higher thrombotic event with aspirin group. So think about people who on their own discontinue aspirin therapy, what will happen to them. So this is an important clinical pointer to suggest that clopidogrel should be used instead of aspirin. So now we are turning against aspirin and into more towards clopidogrel. Important point to note that not all patients will be continued with the other P2Y12 inhibitors like ticagrelor or prasugrel. We have to shift them back to clopidogrel at some point of time, and the agent to be chosen for the later therapies, the lifelong therapy of antiplatelet therapy, should be a single agent, and that also should be clopidogrel. So I think this is all we have to share today for the slides. Of course, my talk was much smaller talk, but then of course the background therapy of high intensity statins is really, really important, and that should be supported with clopidogrel. That's definitely there.
So Dr. Patki, you highlighted what should be the right therapy for people who have SCS and PTCA done. If people follow the right practice, you have delivered an excellent message. And so to have an opinion on this subject, I would put Dr. Kathirsan, kindly unmute yourself. If we see the number of people and the kind of brands available in market, there is a huge number of all statin mono. There is aspirin based combination with statin, and there is also clopidogrel and statin combination where it is clopidogrel as mono and all combined aspirin, clopidogrel and a statin, where I might put it as gold kind of a combination. Now, a huge number of practitioners, you will discharge the patient with what you feel appropriate, and patient is stable over a year. And a common practitioner would tend to feel that something is not necessary now. So they try to reduce therapy. The number of agents which get dropped is like flavidon MR, drugs like ivabradine and whatnot, which practitioners feel that a patient's pill burden could be reduced. So what is your opinion? Why do physicians behave in relation to dropping one of an antiplatelet agent? Why such psychology prevails? Going into the mind of practitioners. Do you think, is it a teaching recommendation from cardiology guidelines? What should be dropped from a therapy? We would not go into flavidon and ivabradine, or reducing the dose of beta blocker now is not required, post MI when necessary. We are presuming that patient does not have heart failure, preserved yes, otherwise would land up with more 4 pillars added onto coronary drugs. Yes, sir.
So this is very important, rightly said. So in terms of 1 year after the therapy, so like Dr. Nitin sir said, the first year of therapy, there is no confusion. We are on dual antiplatelet. But after 1 year of therapy is over for an ACS, we have to assess 2 things. One is the bleeding risk, another is the ischemic risk. So if the ischemic risk is high, we have to extend the dual antiplatelet in certain patients. But if the ischemic risk is less, then we have to move on to the single antiplatelet. Most of the time it is going to be clopidogrel. But if the bleeding risk is high, then an ischemic risk is low, then the same thing, single antiplatelet. The important message will be, if you use a dual antiplatelet, the risk of bleeding is always high. It is an established fact in all the studies. So at 1 year after the PCI or 1 year after the ACS who are medically treated, we arrive at a conclusion to individualize the drug therapy after a year. So the 2 things, one is sometimes the third factor which may be added, or the procedural, what is called as the complex stenting. So if the patient has got a bifurcation stenting, left main stenting, and a very long CTO stenting, then sometimes we extend the dual antiplatelet therapy. So put things simple, 1 year after any acute coronary syndrome or any angioplasty, reduced to a single antiplatelet, that antiplatelet is going to be clopidogrel. But if the ischemic risk is high, sometimes we change over to 60 milligram of ticagrelor also. Thank you, sir.
So these are kind of an option. So Dr. Patki, is there any way by how cardiologists would suggest a recommendation on long-term basis where the drugs do not get dropped? If they continue to follow up with people like you and who understand long-term science, and we take out the time to explain what should be on rather than what should be minus. Prasugrel incidentally exists independent of rosuvastatin, so that gets prescribed separately. Large many patients would have antiplatelet as part of a statin, both Etorva and Rosuva.
Yeah, so a very important point. Actually, what Kathisan mentioned is one important aspect which we need to understand as practitioners or referring people is that the complexity of coronary angioplasty is known to the cardiologist. As he mentioned, left main, bifurcation, stenting, long stent, these are called as complex angioplasties, and where we generally would prefer that patient receives a stronger antiplatelet agent, sometimes even a dual antiplatelet agent for a longer period of time. So I would suggest that this dropping of the agent should be at least be given to the cardiologist who knew what happened during angioplasty. Definitely the risk of bleeding definitely goes up if there are two antiplatelet agents, and always the agent which is blamed is aspirin. So aspirin can be dropped, but the other agent should be continued. So there are some high bleeding risk patients where we have dropped aspirin even earlier. Now we are talking of stopping that aspirin even after 1 month of angioplasty, sometimes after 3 months. But that is basically in people who have high bleeding risk. So always we are worried about bleeding, and there can be ways to still save the stent or save the coronaries by doing imaging techniques so that we land up with a good coronary results, so that the chances of clot formation are less, so risk of thrombotic events is less, and that's how we can reduce the bleeding risk. So these agents can be dropped, but preferable that we ask the person who has done the angioplasty whether we can stop the agents. And of course, if at all the agent has to be stopped, it should be aspirin. P2Y12 should be continued. Of the P2Y12 inhibitors, ticagrelor can be continued for 1.5 years extra, or we can drop it down to 60 milligrams. Prasugrel, generally extending it beyond certain period always carries higher risk of bleeding. So continue with clopidogrel, but yeah, I would still suggest that let the decision be with the cardiologist. If there is dire need, patient has landed up with some emergency surgeries, then of course we can stop one of the agents and continue with aspirin. That's what is recommended. If the patient has some bleeding in the brains or some bleeding which has caused massive GI bleeds, then we need to stop antiplatelet agents definitely. So these are rare situations, but again, concerned people should be contacted.
Thank you, Dr. Patki and both Dr. Kathisan for highlighting. The last question of the day for both of you before we wind up the session is, do you think there is a specific preference of using both the drugs or in combination with rosuvastatin in relation to a combination prescription versus an independent prescription of a statin and antiplatelet?
So I think it has to be considered. One is the socioeconomic factors, and other is the patient pill load. What we normally see in the usual setup is when aspirin is added, that combination comes under the price control. So many a times, this what you said, the goal preparation, the triple combination is given in the initial setting, so that the patients who coming from the far off place or from the rural area, at least they have the benefit of taking it along without any interference. But at the same time, in terms of long-term data, if you look at the patients who have got a high risk, we often find that when you have a triple combination, UJ bleed, upper J bleed is a little bit common in that specific group when compared to only clopidogrel group. And intracranial bleed is of course often less, but we often find patients coming with an UJ bleed. So I will use this triple combination very cautiously, but of course it is useful. At the end of a year, either we have to use separately or we'll go for a statin plus clopidogrel.
So both Dr. Patki and Dr. Kathirsan, we just highlight on behalf of an Aries team that somehow Aries decided to market 10 milligram rosuvastatin, 20 and 40 all at the same price, significantly cheaper compared to many other brands. And so is even the clopidogrel combination with rosuvastatin come at the same price. So with rosuvastatin, anything you add, double up, quadruple, add anything, ezetimibe, everything goes at a flat price. So good for the patient, and a combination, as you said, obviously all would agree in relation to number of pills. So probably might improve compliance. We know that statin is associated with very, very high non-compliance in many people, though slightly less in secondary prevention. In primary prevention, we have a major issue of compliance. With this, I would end my questions to all of you. If you have any message for listeners, you can suggest. Otherwise, we can close, and over to you, Ms. Khushbu Patel. We are at the end of 1 hour and 15 minutes of CME. Anyone? Dr. Patki, we hand over to Aries team if you have any final comment.
Yeah, it was a excellent introduction by you, and you nicely conducted the whole program. Thank you very much. It was really a pleasure to be with you and with Dr. Kathirsan. And the basic message you have already conveyed, that both the agents are important and should be given. And if possible, the high-risk individuals should be investigated and treated so that either they do not land up with ACS, or even if they land up with ACS, they are better protected. Excellent.
Our attempt in a CRIVAST Academy is to expose newer papers, good meta-analysis, guidelines, and cutting-edge science, convert into practical clinical implications with an experts like both of you and other colleagues who have done last 5 programs. We are trying to put up exact science and the way to practice for large number of physicians who join in our CRIVAST Academy program. With that, I would end. Thank both cardiology experts for your contribution. Without that, it would not have been a nice program. Thank you, Dr. Patki. Thank you, Dr. Kathirsan. Over to you, Khushbu, madam.
Thank you. Thank you, sir. Thank you, Dr. Patki, sir. Thank you, Dr. Kathirsan, sir. Thank you very much, Dr. Sanjeev Shah, for all your support. And thank you all the delegates for joining today. Very good evening. Thank you.
Thank you.
Thank you.